palliative hospice has its roots in Ireland and England near the end of the 19th century. The modern concept of hospice was developed in 1967, again in England. In the United States, hospice was originally run by volunteers until the 1980s, when Medicare was authorized to formally provide hospice care. Hospice in Hernando, Pasco, and Citrus counties has become a significant part of the sensitive end-of-life care. Hello, I'm Deanna Damer-Kimbrough, and welcome to our guests from Hernando Pasco Hospice. We have with us Dr. David McGrew, who is the Chief of Medical Services for HPH Hospice, and also he's President of Hospice and Palliative Physician Services.
That's correct.
Hello, Dr. McGrew.
Hello.
And Carla Hayes, who's the Marketing Communications Coordinator for HPH.
Hi.
Welcome. How are
Thank
you? We're in the Sturgill Center, by the way, which is one of the main buildings here on the campus of hospice. Today our topic is going to be palliative care. And palliative care, let's first of all define what that means, because I was not aware of that word until 2004 when my mother received palliative care. So I'm going to just assume a lot of people don't know what that is and understand it.
Well, I'll let Dr. McGrew answer that question because he's the expert.
Well, I think in this day and age, a lot of people do understand what hospice is.
Sure.
Hospice is palliative care for dying people. So most people think about hospice in its relation to death. Palliative care is taking the principles that have made hospice so popular and valuable to people and taking them out into the larger community of chronically ill people. So all of hospice is palliative care, but palliative care as a form of care can be much bigger than hospice.
Okay, so let's describe exactly because I'm sure there are different types of palliative care because there are different types of conditions with people nearing the end of their life.
Well, palliative care basically is a focus on the whole person, more as a person that's got social relationships, spiritual relationships, other issues and needs than just the biological specimen. So medicine tends to get very focused on what's wrong with you and how to fix it. As you get more and more seriously ill with chronic illnesses, there's less that's fixable, and medicine needs to get a little less focused on fixing the unfixable and a little more focused on taking care of you as a person.
And is that where the term curative versus palliative comes from?
Well, that's where some of it is. A lot of that notion comes actually from the oncology world, where so the treatment of cancer, things are either curative, which isn't very much of cancer care, or palliative. So everything that's not curative is palliative. So that those terms can be used and cause confusion, whereas in hospice and in the palliative care world, we think of palliative care as a focus on quality of life as opposed to your disease state. And we have to know something about your disease state and deal with it appropriately in order to make sure that quality of life is actually accomplished. But when you're 40 years old and you've got high blood pressure or diabetes, that needs a different attention than when you're 80 and you've got advanced heart disease and you also have diabetes and high blood pressure. The treatment for the diabetes and high blood pressure is different at that point.
Is palliative care exclusive to a hospice patient, or can palliative care be given to people who they're hoping to be cured or will survive?
Well, it's best to think of palliative care in the United States right now more as a concept than a form of care.
Okay.
It's a concept about care in the same sense that hospice was a concept about care before it became a form of care. And then because the concept had merit, volunteers started providing hospice care. Because volunteers were providing hospice care, somewhere along the line, Medicare said, hey, we need to provide a payment mechanism for this. And that's really what caused the hospice industry to grow in the United States. Palliative care outside of hospice is in that same kind of place right now. There is no payment system for palliative care. So the people that believe in palliative care, either at the industry level, within hospitals and within hospices and other centers, are trying to figure out how to provide this concept of care given a payment system of care that is not really suited to this kind of care.
And I understand, especially when you're dealing with Medicare or insurances, it starts getting even more and more complicated.
Right.
So thank God for hospice. I was interested, you mentioned some of the needs that hospice responds to using palliative care, and you mentioned things like spiritual. I think we talked about at one point depression. How do you apply palliative care to those parts of a person's life?
Well, Dame Cicely Saunders, who is credited as being the mother of the modern hospice movement, recognized, she actually started her life as a social worker, and in caring for dying patients, she realized that she didn't have all of what she needed to really provide for their care, so she went back and became a nurse. She did that for a while, realized that she was still limited, and she went back and became a doctor. And so she was like a whole person, a one-person interdisciplinary team. She had spiritual sensitivities. She recognized when she formed hospice that people, particularly dying people, need all these dimensions of their life addressed, not just the medical dimension. So that's kind of the way she codified hospice care, and that's the way it got implemented in the United States. Palliative care is a little less focused on the interdisciplinary team, but still there, because we're still trying to get away from dealing with the person as a biological specimen and deal with them as human being. So that does involve, social, emotional, financial, spiritual issues that are very unlikely to get dealt with in your typical hospital stay, for instance. So the things that get focused on in palliative care might be very different than what would get focused on during your hospital stay, because as a human being, there's other things that are important to you. So your depression and pain and other distressing symptoms are at the very center of concern in palliative care, because you can't have a good quality of life if you're in pain. So what we see a lot more of in the world today, in the United States, is advanced illness with multiple chronic illnesses. So these people wouldn't have been alive 40 years ago. They're alive still because we kept the things that would have killed them from killing them. And now there's a very different need within that population of people. And that population of people, when they go to the hospital for the problems that, a younger person that doesn't have all that stuff going on might go. If I go in the hospital and I'm reasonably healthy going, I anticipate that the hospital is going to fix what I go in there for, and I'm going to come out better for it.
Right, sure.
Increasingly, as people get older with more chronic illness, they go into hospital sick, they come out sick. There's not that much difference between their pre and post-hospital state. So many people are looking at that and saying it's not working. It's not working to continue to apply the same form of care to a very different population of people.
Maybe then the more appropriate question at this point is, where can palliative care through hospice be offered? It used to be you had to come to a hospice facility. Does hospice now go to assisted care facilities or hospitals even, or even to your home? Have they expanded that?
Well, actually, what you said about the way it used to be has always been a misconception about hospice.
Oh, okay.
Because it's never been predominantly a point of care. It's always been a concept of care, and the majority of hospice care in the United States, from its inception, was provided in people's homes.
That's right. I came across a quote that I think it's very appropriate at this point, is hospice is a service, not a physical place.
Right.
And I didn't know that until I was looking up some information about it. If you understand that, it helps you understand what we were just talking about in terms of the
Well, one of the
function.
biggest misconceptions is that all hospices are the same, and that is a misconception because, well, for instance, we're a non-for-profit. There are for-profit hospices, and not every hospice has this type of a care facility. Is that correct, Dr. McGrew? I mean, this is, not special to HPH, but it's not available in every hospice setting that, that you would find. So
we're very fortunate here in Hernando County, and I realize that you serve Pasco and Citrus.
Right. This is one of 4 campuses that we have in the 3 counties that we serve. Right.
And this has grown by leaps and bounds over the last, I'm going to say 20 years, but
the majority of our care is in the patient's home or wherever they call home. So if they live in an assisted living facility or in a nursing home, if that's where they need to be cared for, that's where we will take care of them. However, we don't treat patients under hospice in these 3 counties in a hospital setting, correct? We have referrals from hospitals, but we don't take care of them in a hospital setting.
Which means it's very important, if you're considering hospice, is to get out and get some information about the nearest hospice or the one that's in your very county. Can you describe, can you do a for instance kind of thing? If somebody is under hospice care, means they're at end of life. The end of life is determined by their doctor. Is that true? And then hospice is called in?
Well, it can happen a variety of ways. So if you see your loved one failing, and I try and emphasize that anybody can see this stuff happening. You see somebody that's had significant functional losses that are going on and unfixable, weight loss that's happening, any disease progression. You can see this happening. You can initiate referral for hospice yourself.
Because the loved one very often knows that person best and sees the changes.
Absolutely.
Right. So I could make the call.
You could make the call, and then what hospice would need to do is get a physician order to do the evaluation. Now, they could get that physician order from your attending physician, or they could call one of the doctors in my group, would get a referral, they would do the evaluation. Ultimately, 2 physicians have got to agree that the person does indeed have a limited prognosis. So once we gather the information, then we make that determination, and the person would be admitted to hospice. Because the 2 things that qualify you for hospice under Medicare, and that's where the most of it happens, is you have a terminal prognosis, which is less than 6 months of expected life, and a terminal diagnosis.
And that must be a relatively, that has to be an average thing. I'm going to assume there have been people that haven't made it to the 6 months, and maybe those who have gone past that.
Well, actually, the big problem that hospice has always dealt with, and it's actually gotten worse over time, is that we end up seeing people at the brink of death instead of the end of life. So I think we're currently at about 40% of the people that are admitted to this hospice are dead in the first 2 weeks.
Is that right?
And that's again because people wait, they wait to get the hospice care for the patient, and they don't understand, the eligibility and the advantage of having hospice care, not just for the family, but for the patient, but for the entire family.
And I was wondering if it's a bit of a denial.
There's some denial in there. There's some denial on the patient's and family's part. There's some denial on the doctor's part.
Right. Okay.
There's some dysfunction within the healthcare system that contributes to it. There's mixed incentives and payment structures that contribute to it. There's a lot of things that contribute to it, but it's one of the problems that we face in end-of-life care, for sure.
What, for instance, if somebody, I'll go back to my scenario, somebody has decided to call in hospice. You go to wherever the patient is. What's the chain of events? What happens first?
Well, generally, a nurse is going to go do, once we've got the referral, a nurse is going to do the evaluation.
A hospice nurse.
A hospice nurse will do that evaluation. And there's also a hospice social worker that's involved at the time that admission decision's actually made. But the admission nurse would call one of the physicians in my group, review the case, and we would give the second voice about admitting the patient to hospice. At that point, then the admission gets finalized by the admission nurse and the social worker. They bring that information back to the team and then involve other elements of the team as needed. So the chaplaincy, volunteer services, physicians would be engaged in the care of that patient at that point.
A typical team then would be made up of a nurse, a physician, a consulting physician, and a social worker.
Social worker.
Are there other?
And chaplains.
A chaplain.
Home health aide.
Talk
Home
about
health
spiritual.
aides.
Home health aide.
Okay. All right.
Volunteer,
coordinator.
bereavement.
Coordinator. Yeah.
This whole interdisciplinary team.
Yeah, the teams are actually about 20 people, but there's duplication of, so the team has multiple sub-teams in it that take care of people.
Yeah.
It's amazing, and we talked about. I understand hospice is not a place; it's a service. But they do have, especially on this campus, I believe you have a situation where patients can come here and stay.
To this facility here.
Where we are right now, Sturgill
This is
Center.
a 24-bed inpatient facility.
How does someone qualify to be able to come here?
Best way to think about this is hospital level care within hospice. So there's an acuity of need, so healthy people don't go to the hospital, normal hospice patients don't come here. This you qualify for because there's some acute symptom crisis, some problem with handling that wherever you are. So somebody has a new pain crisis or some nausea, vomiting, breathing problem, it's not being handled well in a home setting, they can come here where they would get seen every day by a physician, be cared for around the clock by nurses, and we get that fixed, and hopefully then they return to where they came from.
And they can come back again if they need to, but...
All right, that was another one of my questions, is you have had people who have left, but they've come back.
Oh, sure.
Okay.
And that's one of the things about hospice care that people don't know as well, is that if they decide at any point during their association with hospice, if they want to revoke with us, they can do that, and then they can come back again at a later time if they decide to. So let's say they're under hospice care, they decide they want to seek curative treatment for whatever their illness is, or for whatever reason, they can revoke their agreement with us and come back, correct?
Well, and also, aside from revocation, which is the patient's decision to leave hospice, sometimes we have to discharge people because they no longer qualify as terminally ill.
Right.
So there are people that we encounter in a crisis, they stabilize, and then they need to be off hospice.
Right.
Well, it's funny because I really was going to ask that question. If you've ever had situations where, guess what? They're not really at the final stages or terminal part of their life.
Well, actually,
so that does happen?
Between 10 and 15% of the people that get admitted to hospice are discharged alive.
Wow.
So it's not unusual at all for it to happen.
And you mentioned something else, Dr. McGrew, about the patient still has some rights. And if they are conscious and coherent, etc., they personally can say, I don't want to be here anymore.
Absolutely.
Okay.
I think one of the things that characterizes hospice and palliative care is that it keeps the patient very much at the center of what's happening, whereas I think many times patients and families feel like they get lost in the machine of modern medicine.
And I think that's typical of medicine in general and the healthcare system, as you alluded to earlier when you said some things are broken about it. We'll take a real quick break here, and then we'll come back and talk more about hospice with Dr. McGrew and Carla Hayes on Hernando County Government Broadcasting.
This program is sponsored in part by HPH Hospice.
Welcome back to Focus on Hernando. I'm Deanna Damer-Kimbrough. Our guest today from Hernando Pasco Hospice. What a great organization. I'm going to just wear it on my sleeve. I have been in love with hospice for years without even knowing exactly all of what you can do. So it's getting, the love affair is growing more. It's growing. Dr. David McGrew is here and Carla Hayes. And I want to talk about a very sensitive topic that relates to hospice care, is children. Dr. McGrew, can you talk about what happens for children who come to hospice? Is it the same routine? Do you have a lot of children that seek hospice care?
Well, how many children a hospice sees depends largely on where they are. Now, in this community, most of the people who end up with seriously ill children go south to Tampa and St. Pete. So we've got some excellent children's hospitals down there. they tend to develop their relationship there. And if their children are not getting better and they're failing, many times they stay in those communities. So a lot of the hospice care for children is provided in Hillsborough and Pinellas counties. We do have some children that come up here, sometimes newborns that are born with fatal sorts of anomalies, anencephalics and other things. We don't end up with a high volume of children in this hospice. But to answer your question in a more general sense about children in hospice care, you know, if I'm 80 years old, chronically ill, and now am dying,
You've led a good life.
It's a little easier for everybody to acknowledge that I'm dying.
Right.
There's never a good time for a child to die.
I can't imagine.
It never seems like a timely death, and so we expect, anticipate, and tolerate a whole lot more ambivalence in the whole process with parents and children. So you see a lot more of tension between the curative and palliative sort of goals of care, whereas we're trying to encourage chronically ill people and terminally ill adults to let go of the curative focus, you know, and get rid of the disease focus and focus on the human being. With kids, you don't quite get to that same place. So there's a lot more tension, but the reality is that kids still get things they die from.
Yeah, I almost knew, before you even said what you just said, I almost knew that's where we were going with this, because as I said, I can't imagine facing that with children. But, well, thank you. I wanted to clear that up to make folks aware that there is hospice care for children, and sometimes that can bring comfort to the family, just like as you mentioned, the aging.
A very big part
patient.
of what hospice does is for the family. So, you know, when all is said and done, the patient we're taking care of is going to be dead, and the family is going to live on. And so good care of a dying individual and appropriate care of that family unit results in good bereavement and people being able to heal to the extent that anybody can heal from loss, but heal and get back to a state of wholeness and move on with life.
Right.
And so that's a really big focus of what hospice does, is to help in that whole transition.
And that brings me, probably it's a very nice segue into my next question, has to do with volunteers. Because I, over the last few decades, have known volunteers, and I always think, how can they do that? Very often, they have been the family beneficiary of what hospice does for their loved one, and they want to provide that same.
They want to give back.
Right.
They really, and they're some of the most dedicated volunteers that I've ever had the pleasure and honor of working with. And we have many opportunities for volunteers. If people aren't interested in any kind of patient contact, which I totally understand that. There are opportunities like helping out here at the Sturgill Care Center in the kitchen. We have volunteers that help, doing filing and clerical work. We have volunteers that help with our inter-office mail, deliver mail. We have a wonderful program that's called We Honor Veterans, where we use veterans that volunteer. One of the services we offer is we will honor that veteran that's a hospice patient and thank them for their military service. So part of the social worker's role in that is that they go through this military history checklist. So it's our goal to identify any veteran in our care. And if they choose not to have that ceremony, that's perfectly fine. But if they would like to, we do a pinning ceremony where we thank them, give them a certificate and a pin, and we use that veteran to go in and speak to that veteran because they relate better to each other. So a lot of different opportunities for people to volunteer.
Can they give you a call, and we'll give out the website too? Who should they call?
Well, they should call. They can call this campus. It's the number here is 352-597-1882. And you would ask for someone in our volunteer department. Ann Clark or Jacqueline Lambert are the two volunteer coordinators for Hernando County. And we ask each volunteer to go through a 2-day orientation. And we take our volunteers very seriously. We do a level 2 background check. You get fingerprinted. drug tested, and then once you've gone through that process, then whatever your interest may be. We have people that sing. They're the hospice high notes. They go around to facilities and sing at, say, Evergreen Woods once a month. We have, we call Compassionate Paws, and these are volunteers that have the therapy dogs that visit patients.
I've seen some of those. That's amazing.
We have 11th hour volunteers that sit with patients that are dying that have no one else to be with them.
Now
and that's
that takes some courage, doesn't it?
Yes,
that,
absolutely.
That one takes some courage.
So you could see, I mean, we couldn't perform our mission if it wasn't for the generosity of these volunteers. Very, very great group of people. Absolutely.
Thank you so much. This has been so, for me personally, enlightening, things I didn't know, so I'm hoping that our viewers will be shaking their heads. Yes, I didn't know I need to be in touch with hospice, either for information about their loved one or perhaps to volunteer or anything else. I know you have some great brochures, etc., and just they could tour this lovely campus. It's great.
Always available to come and speak to groups. We have a great program that we talk about advanced care planning and how to choose a healthcare surrogate, fill out your living will, stuff that's very important, that's very pertinent to your ability to choose what kind of health care you want, what kind of decisions and you want to make. So
we'll give out that website, and I'm sure that we'll have it on the screen too, www.hph-hospice.org.
Yes.
All sorts of information on there. And I want to thank you, Dr. David McGrew, for all the years that you have put into hospice. We'll make a program on that someday. Just
30
all of
years.
That. 30
that's
years.
Amazing.
And Carla Hayes, thank you so much for the work you do for
Thank you.
educating people about hospice. Thank you so much. Thank you for tuning in, and we'll talk to hospice again. Thanks for joining us on this edition of Focus on Hernando. I'm Deanna Day McKimbrough.
This program sponsored in part by HPH Hospice.